Thank you to all of you, and thank you to the Society of Thoracic Radiology for this kind invitation to spend some time today. So I have no financial disclosures. I've been very active in lung cancer screening in many organizations, including I chair the American Cancer Society's National Lung Cancer Roundtable here in the United States. I now chair the American College of Radiology suite of national data registries and was the inaugural chair of the lung cancer screening and lung RADS committees. And I also serve as the vice chair of the lung cancer screening panel for the National Comprehensive Cancer Network, which is a network of major cancer centers in the United States. What I'm going to talk about today is why should we screen for lung cancer? We screen for other cancers, breast cancer in women, for example, colorectal cancer, but why screen for lung cancer? We'll talk about that. Review the guidelines that we have for lung cancer screening here in the US and the studies on which they're based, mostly performed in the US and Europe, but also studies that have been performed, mostly cohort studies in China, Taiwan, Korea, Japan. Partly I'm going to get to interpreting lung cancer screening CTs. What is it that we're looking for on these exams? How do we interpret them? What is the risk of cancer and the various type of nodules? And how do we communicate to patients what a lung nodule is, some spot in the lungs? And then lastly, I'll come to how the population at risk for lung cancer may be a little bit different than the general population. We're working in the US hard to increase lung cancer screening rates by the most recent data. We're somewhere between about 18 and 20% of people who are eligible for lung cancer screening are now getting screened. But there are a lot of barriers to overcome, some of which are societal, cultural, and related to the stigma associated with cigarette smoking. So my journey as a radiologist has, I think, been an interesting one. As a cardiothoracic radiologist, I never envisioned myself as being a public health advocate, but I think that's what lung cancer screening is all about. We have the science, we have the studies, we know that it works, we know that it reduces lung cancer mortality, but it's a big jump to go from science to actually changes in practice. It means policy changes, which can be at your national level to get coverage, to get investments in health systems to be able to provide the service. It means really digging into implementation, helping facilities get the resources and to do lung cancer screening with quality. And it's not just enough to put out a guideline. How do you actually get people to do screening? What tactics, barriers, and drivers can you bring to bear? This is particularly important when we talk about public health tests, breast cancer screening with mammography, colorectal cancer screening, and lung cancer screening. So I see myself as a person, a human being, a physician, a radiologist, but also a scientist and an advocate for public health. I like to say that the face of lung cancer is changing, and I think it really is. Early detection for lung cancer is a combination of lung cancer screening, which we're going to spend most of our time talking about, but also incidental lung nodule programs are increasingly being recognized to make sure that when we find lung nodules on radiology tests, that we're actually following those highest risk nodules. That way we can catch early cancers, often for people who are not eligible for screening. But there have also been so many advances in lung cancer treatments, surgical, percutaneous treatments, radiation therapies that are more targeted and less damaging to the lung tissue. And also for people who have advanced stage cancer beyond screening, immunotherapy and biomarker-based targeted therapies are really changing the face of advanced cancer. So now we have patients who are surviving 8, 10, 12 plus years because of these types of therapy who have metastatic disease. We're seeing a slow shift from individuals who currently smoke to individuals who used to smoke to individuals who never smoked, and research going on to understand the benefits of lung cancer screening in that population. A lot of work needing to be done in that space. I'll touch on this topic towards the end, which is it's important to treat patients as individuals, especially people who have cancer, no matter what cancer they have, free from stigma in a way that inspires hope and not fear. As I mentioned, anyone who has lungs can get lung cancer, and we're increasingly recognizing the population of lung cancer is changing. Now, around the world, in most countries, lung cancer is the #1 cause of cancer death in both men and women. There's a few variations around the world, but in general, when you look at international cancer statistics and look at most countries, lung cancer is the leading cause of cancer death. And that's because we have a risk factor in cigarette smoking. We have a cancer that is hard to detect early. There's no symptoms when people have a nodule in their lung. And by the time it's presented historically with symptoms, symptom detected cancer, it's usually spread, and the 5-year mortality, the 5-year survival has been pretty low. If we look at the lifetime probability of developing lung cancer, in men, it's second only to prostate cancer in frequency, but lung cancer kills more men than cancer of the prostate, colon, melanoma, kidney, renal, pelvis. Of all cancers combined, the top 5 cancers, lung cancer kills more men and women than many of the more common cancers combined. So my message is quite simple, which is lung cancer screening saves lives. A low-dose chest CT requires little preparation. It can be a high volume examination, no IV in terms of patients getting on the scanner, taking in a breath and hold it, taking the images and then off to the next patient. So you can generally do these in a more high throughput manner than exams that require drinking oil contrast and IV contrast injections. But early stage lung cancer looks like the image on the left, a spot on the lungs, a small spot on the background of a normal density tissue. Whereas advanced cancer, its symptom presentation, invading the mediastinum, narrowing the pulmonary vasculature, obstructing the bronchi, is much harder to treat. We have hope for these patients with advanced therapies, but early detection is likely to be curative. There are 2 major trials that were performed in the U.S., beginning with the LCAP trial, which was the first single-arm prospective cohort study performed by Claudia Hedgeby, David Yankelevitz, and colleagues, and published back in 1999 in The Lancet. And this was 1,000 patients who were at high risk for lung cancer by age and the amount of cigarette smoking they had, and they followed them forward with annual low-dose CT and looked at the ability to detect cancer. And this was the first study to show that we could detect cancer early, and they had a 2.7% cancer detection rate in this population. This type of study and other cohort studies allowed us to perform the National Lung Screening Trial here in the United States through the National Cancer Institute. This is over 50,000 patients in a randomized trial. We screened annually for 3 years, and we followed patients for nearly a decade. And the results of this trial were published in the New England Journal of Medicine in 2011. Subsequent to the NLST demonstrating a mortality reduction of 20%, the Dutch-Belgian trial, known as the Nelson trial, was published in the New England Journal of Medicine in 2020, the second large randomized controlled trial that was large enough to demonstrate a mortality benefit, and showed similar results to NLST. And other studies, such as the MILD trial in Italy, the multicenter Italian lung cancer detection trial, was published in the Annals of Oncology in 2019. So the evidence is there in randomized controlled trials that lung cancer screening with low-dose CT done annually reduces lung cancer mortality by approximately 20%. So in the National Lung Screening Trial, as I mentioned, the first randomized controlled trial, we showed a 20% lung cancer mortality reduction and approximately 7% all-cause mortality reduction. Remember, this is a population who is at high risk for other conditions besides lung cancer due to the history of cigarette smoking, and cardiovascular risk and coronary disease and stroke play a particular part in this patient population. It takes screening approximately 320 individuals to save 1 from a lung cancer death. This study enrolled individuals who are 55 to 74 years of age, had a 30-year history of cigarette smoking or more, and either currently smoked or had quit in the last 15 years. And this is the type of study data that led to the first guidelines here in the United States. The cost effectiveness of lung cancer screening was also published by the National Lung Cancer Screening, demonstrating an approximately $81,000 cost per quality adjusted life year. which in the US is in line with other cancer screening tests. This led to changes in our national guidelines. Our U.S. Preventative Services Task Force is a body largely of primary care physicians and scientists who make recommendations for preventative health services here in the U.S. that are largely executed through primary care practices. These national recommendations have implications for us because it determines, in many ways, the insurance coverage that follows. In 1996, they issued their first lung cancer screening guidelines, and at that time, there was no data to support lung cancer screening, so the recommendation was a very low quality recommendation. In 2004, 8 years later, they reviewed our guideline here in the United States. There was now some early data on single cohort studies for low-dose CT, but no randomized controlled trial had yet been published. There had been several trials conducted in the U.S. in the past of chest X-ray and sputum cytology, neither of which demonstrated a mortality benefit. So again, we have no favorable recommendation. But in 2013, based on the results of the National Lung Cancer Screening Trial, they issued their first favorable recommendation. Grade A and B are considered positive favorable recommendations in their schema that lung cancer screening should be performed. Their recommendation extended the age criteria that were used at NLST up to 80 years of age, whereas NLST stopped at a younger age. And this was done through modeling studies. They used the same Packer criteria of 30 pack years cigarette smoking, either currently smoking or quit within the last 15 years, that was used in NLST. Importantly, they recommend that screening should be discontinued if somebody has not smoked for 15 years, and we'll come back to that or more. But if they develop a health problem that substantially limits their life expectancy or their willingness to undergo curative treatment. The most recent USPSTF guideline has actually expanded the screening population, lowering the age to 50 and lowering the pack years to 20. This increases the number of people eligible for lung cancer screening in the U.S. from about 8 to 9 million people to just over 14 million people. Most of this work came through additional modeling studies based on the published available data to show that individuals with a lower pack year smoking habit and a younger age are at high risk for lung cancer. In particular, this addresses some inequities in lung cancer screening, and that individuals, largely women and Black Americans, may have different smoking habits and a higher risk of lung cancer. This did, in fact, increase the number of Black Americans and women eligible for lung cancer, but it didn't really close the gap because it increased eligibility for the entire population. When our U.S. Preventative Services Task Force issues its guidelines, it always publishes its scientific recommendations and the data on which it is based. The 2021 recommendations were published in the Journal of the American Medical Association. More recently in the United States, we've had an update to the guideline from the American Cancer Society. This has not yet been widely adopted by other professional organizations or the U.S. Preventative Services Task Force because it's very new. It only came out at the end of last year. So in 2013, the American Cancer Society's recommendation was similar to what I said USPSTF started with. But the important change is they dropped the years since quit criteria because extensive evidence that they developed and analyzed for their guideline updates showed that individuals beyond the 15-year quit date continue to be at high risk for lung cancer. And a large part of that is because lung cancer risk continues to increase with age. So at the end of last year, the American Cancer Society dropped the years since quit criteria. We're now in the advocacy stage with the U.S. Preventative Services Task Force and our payers like Medicare in the U.S. to see if we can make those changes in their recommendations and coverage and policy so that patients who were not eligible before will become eligible. This now increases the screen eligible population to almost 19 million individuals. In doing this work, the American Cancer Society published a systematic review of the evidence to support dropping the 15 years quit criteria. And the clear message is that people remain at high risk for lung cancer beyond the 15 years since quit. Basically, for decades, we have confused the relative decline in risk as an absolute decline in risk, misleading individuals and ourselves in the scientific community about individuals who quit beyond 15 years. If all eligible individuals follow this new guideline, 21% more lives are expected to be saved in the US and 19% more life years gained, but just over 19 million people now eligible, largely because as people become older, they who have quit, they're retained in the screening pools. Let's move a little bit into some of the more radiology-specific content. We know the scientific evidence, we have guidelines on based on data screening, but now we're doing these screening exams, so how do we interpret them? In 2014, we developed the first lung-RADS as an interpretation schema to help radiologists report lung cancer screening exams in a standardized manner, so that whether you are on the East Coast, the West Coast, small community hospital, or a large academic or integrated medical center and health system, that the same criteria would be used for interpreting lung cancer screening, and that our referring clinicians and ordering providers would have some consistency in the recommendations that were being made. And this was really important because Medicare and others were very concerned that there would be over-testing, too many biopsies, too many PET scans that were unnecessary, costly, and may even cause harm in the form of unnecessary procedures. So having standardization is really important. We've always said that lung-RADS should be updated as the science evolves, and we updated it in 2019, and then again in 2022. This common lexicon and definition standardizes practice among radiologists for communication with the ordering providers. It defines what is a positive screen, as well as where we're uncertain about positive screen management. It also makes recommendations for each level of positive screening or what should be done with that abnormal test results. It can be used to facilitate quality assurance and improvement. You can track your radiologist similar to what is done in screening mammography to see if you have individuals who tend to read on the high positive rate or the high negative rate instead of more uniformly across your practice, to try and see if there's opportunity to improve performance. To date, there have actually been well over 222 publications in the US and international literature using lung-RADS. So it's really been broadly adopted in the US and in many countries around the world. Well, what is lung-RADS based on? It's based on identifying pulmonary nodules and seeing if they grow or they're stable over time. It takes nodules based on their consistency. Solid, part solid, and non-solid, otherwise known as ground glass nodules, are the majority of nodules. More recently, lung-RADS added to it in 2022 a section on cystic nodules, for which there's much less evidence, and we hope to learn more by having a classification scheme and following them using lung-RADS to see if what we put into practice works. Lung-RADS includes this concept of benign nodules versus benign behaving nodules and clinically active cancer. It begs the question, what is cancer? There are many small nodules, particularly small ground glass nodules, that if you were to surgically resect them, they would be adenocarcinoma under the microscope. But their behavior is relatively benign. So you'll see in lung-RADS, we follow ground glass nodules until they become a certain size or they develop a solid component indicating they now have an invasive component. Now, in countries like Taiwan and Korea, a lot of data has been published about taking out these types of nodules earlier, particularly in a patient population that doesn't have smoking history. Some of the exposures may be related to cooking gases in poorly ventilated kitchens, and they're seeing this predominantly in women. So they have been doing screening trials of women who have never smoked cigarettes. Maybe there's something genetic there as well, where there may be these other environmental exposures in doing screening, and they're picking up ground glass predominant cancer. It's led to a higher surgical resection rate, but it hasn't yet been shown to reduce mortality from doing so. There's a lot of questions out there to understand about that. By using lung-RADS compared to what we used in National Lung Screening Trial for interpreting screening exams, which is similar to Fleischner, it reduces the false positive rates So what's the we're doing when we find nodules? We classify them to solid. Here's a typical smoothly marginated solid nodule in the middle lobe. To the pure ground glass nodules here on the right, where you can see the blood vessels in between the area of ground glass. The part solid nodule, which has a solid component in the middle and a ground glass component. So that's our first step, finding nodules and then classifying them using the schema. Well, why do we use this ground glass to solid continuum? It's based on the 2011 updated International Association for Study of Lung Cancer, American Thoracic and European Radiological Society's European Respiratory Society guideline that was published as a multidisciplinary classification of lung adenocarcinoma. And this was quite a big piece of work by these organizations, and so far it's held the test of time since then. They divide adenocarcinomas into pre-invasive lesions, minimally invasive lesions, and frankly invasive adenocarcinoma. And that's the spectrum of images you're seeing here on the right, from the small ground glass nodule to a bigger ground glass nodule to one that's developed a solid component to your frankly invasive adenocarcinoma. These pre-invasive lesions include atypical adenomatous hyperplasia, usually a very small ground glass nodule under 10 millimeters, which represents a local proliferation of atypical type 2 pneumocytes. And then includes the second component, which are adenocarcinomas in situ. These are pure ground glass nodules, generally 3 centimeters or smaller, with purely lipidic growth. And complete resection of these nodules achieves 100% disease-specific survival. So if you're taking out a lot of pure ground glass nodules and nobody ever comes back with a recurrence, it begs the question of its overdiagnosis in terms of the significance for the population undergoing these procedures versus following these ground glass nodules until they next make it into the next category and go from pure ground glass adenocarcinomas in situ to what we call minimally invasive adenocarcinomas. These are still 3 centimeters or less in size and predominantly, but not exclusively, lipidic, but they have a 5 millimeter or smaller invasive component. So they have this ground glass component, but they also have a solid component. They've developed an invasive component. That's when we really want to act on pure ground glass nodules, when they develop that solid component. These adenocarcinomas that are minimally invasive do not invade lymphatics, blood vessels, or pleura. There's no necrosis in these tumors, and complete resection achieves a nearly 100% disease-specific survival. People have asked about the size threshold that we use for a positive lung cancer screening exam in lung rads for solid nodules, because those are the most common nodules. And some of this data comes from the LCAP study, where they looked at over 21,000 individuals and they looked at their baseline CT. This was a population over a number of years. And they looked at different size thresholds. If they used 5 millimeters and larger to define a positive screen for a solid nodule, 16% of people would be called a positive screen. If they want to just 1 more millimeter to 6 millimeters, it reduces the positive screen rate to 10%. So those smaller nodules would not be considered negative. And if you continue to increase your size threshold, 7, 8, 9 millimeters, and so on, you'll continue to decrease your positive screen rate. But if you decrease it too much, you have to be worrying about what you're missing and will you have patient harm by delaying cancer diagnosis. When they went up 1 millimeter at a time, they also looked at the reduction in follow-up testing. And by simply going from 5 millimeters to 6 millimeters and reducing the positive screen rate from 60 to 10%, they reduced the number of follow-up tests performed by 36%. So the fewer positive screens, the less follow-up diagnostic tests. When looking at the 9-month delay in cancer diagnosis between the 5 and 6 millimeter threshold, 0% of patients had a 9-month or longer delay in their cancer diagnosis. And that's why you'll see in lung rads on baseline screens, we use 6 millimeters for solid nodules as the size cutoff between a lung rads 2 and a positive lung rads 3. When you start to go up from 6 to 7, 7 to 8, and 8 to 9 millimeters, you start to see patients who are having a delay in their cancer diagnosis of 9 months or longer, between 5, 6, and even nearly 7% if you use the highest size threshold. So to avoid delays in cancer that occur by using 7, 8, and 9 millimeter thresholds like this of 5 to 7%, 6 millimeters seems to be the sweet spot on baseline CTs. Patients don't necessarily see nodules the way radiologists see nodules. A nodule is some amorphous thing. What is this nodule, you tell me, doctor, that I have in my mind? In the U.S., a wonderful advanced practice provider in New England area has developed something called pocket nodule. And it's actually a three-dimensional tool, which it fits in like the pocket of your white coat or suit coat. And it has, these are three-dimensional things that you can actually feel. And it shows the size of what a 2, 3, 4, 5 millimeter nodule are, where our negative screens are. And then it shows the sizes of the bigger nodules, 6, 7, 10, 20 millimeters, mostly the smooth nodules. And it also, patients can palpate what is a lobulated nodule, a lumpy, bumpy, but smoothly marginated nodule, or a spiculated nodule. So it makes it live for patients. You know, doctor, what is this nodule? This explains to patients in a common way. They can't palpate a lump in their breast, like kind of lump in your breast, but they can actually feel this and see, you know, what is this nodule that you're telling me, doctor, I have. It helps them understand this concept. So in 2022, when we updated LUNGRADS, we included a category for atypical pulmonary cysts bordering on cavitation nodules. We made some clarification to remind everybody that 30 millimeters remains the size cutoff for ground glass nodules between negative screen 2 and positive screen category 3. And we made some updates that included clarifications and extension of what's a benign intrapulmonary lymph node and pleural nodules. We added some information on airway nodules and some clarifications about nodule growth, stepped management, how to handle potentially infectious or inflammatory abnormalities. And then this S modifier, which is for incidental findings that aren't cancer but may be significant, like an aneurysm. Well, LUNGRADS schema is basically a table. This is the part of the table for negative screening. This is available on the ACR's Lung Cancer Screening Resources webpage, and where we like to keep all the updated information. Category 0 is if you can't clear the lungs. Maybe there's motion artifact throughout it. Maybe there's multifocal pneumonia, and that prevents you from identifying potential cancers. Or maybe it's a technical reason that a part of the lungs wasn't included in the scan range before the images were checked in the patient lab. The LUNGRADS 0 is basically an indeterminate screen. We can't clear the lungs, and we usually call patients back for infection within about 30 days of treatment of infection, or call them back to either do a better breath hold or make sure we get the rest of the lungs in. Categories 1 and 2 are considered negative screens. Negative is basically no non-calcified nodules. And any nodules in category 1 would be those with definitely benign features like a fat-containing hamartoma or specific benign patterns of calcification. In category 2, we call it benign or benign behaving, because they may be small, non-calcified nodules, either ground glass or solid, that are not of high enough risk of cancer to do anything about them between now and the next annual screen in 12 months. These include solid nodules using that 6 millimeter size threshold I mentioned at baseline. But if it's a new nodule at 4 millimeters in the first scan, that's the size threshold between a 2 and a 3 positive screen. For ground glass nodules, I mentioned the size threshold is 30 millimeters between category 2 negative screen and category 3 moving to positive screen, and so on. And then we have the positive screens, categories 3, 4A, 4B, or 4X, when the radiologist is seeing features that are increasing their suspicion for cancer that may not be codified in the LUNGRADS schema. And you'll see for each category, we talk about the solid, part solid, non-solid nodules. We added this atypical pulmonary cyst, and you'll see where relevant this airway nodule category. Most intra-airway abnormalities are secretions, but very small percent of patients, they're not. So I don't intend to go through each and every size threshold, but referring to this Lung-RADS document and the table is really important when interpreting lung cancer screening exams. With each increase in number is an increased risk of cancer. There are not as many exams that fall in the highest risk categories. About 4% fall into the 4A and 2% in this highest risk 4B. But when we do find these more suspicious nodules, it's very important with the highest risk that we move on with a diagnostic assessment, which might include a CT with contrast, a PET CT, a tissue sampling, and importantly, management by a specialist. I want to point out an example of the ground glass nodule. And this is a patient who has a baseline CT and screens at 1, 2, 3, 4, and 5 years after that. And we have this ground glass nodule. It really hasn't changed much over 6 annual screening exams. This is an example of something that would be an adenocarcinoma in situ that isn't growing. It is not demonstrating malignant behavior. And we continue to follow. But when we have a pure ground glass nodule, this came from some of the early work of David Yankelevitz and colleagues, now at Mount Sinai, a pure ground glass nodule at 2 years, it hadn't changed. But at 9 years, it started to develop a solid component. That's when you pure ground glass or solid nodule, a ground glass adenocarcinoma with a solid component indicating an invasive component has developed in the adenocarcinoma in time to act. I think it's important to cover this topic of juxtapleural nodules, which represent benign intrapulmonary lymph nodes. And by calling these out as benign intrapulmonary lymph nodes, they don't need to be followed because they're benign nodules, benign lymph nodes. These can occur along any pleural surface. The original research looked at them along the fissures, perifissural nodules, but additional research, all of this coming from lung cancer screening data, shows that nodules that meet the criteria for a benign intrapulmonary lymph node can occur along the fissures of the pleural surface, but they can also occur on the costal pleura, they can occur on the mediastinal pleura, they can occur along the diaphragmatic pleura. So any juxtapleural nodule that meets the criteria on any pleural surface can be called a negative exam. Perifissural nodules and juxtapleural nodules on the pleural surface were originally reported along fissures. Typical benign perifissural nodules, biconvex, ovoid, lenticular, or triangular in shape. If they get spiculated, if they have acute angles with the pleural surface, these are not considered benign intrapulmonary lymph nodes. So it's important to know what a typical intrapulmonary lymph node looks like. These are examples along the fissural surface, triangular, less than 10 millimeters in mean diameter as an important criteria. Here along the costal, the mediastinal pleura next to the heart. Here along the costal pleura next to the rib, and here along the diaphragmatic pleural surface. So ovoid, triangular, lenticular on any pleural surface under 10 millimeters in mean diameter. We call these benign intrapulmonary lymph nodes. They would go into the category 2 of Lung-RADS as negative screen. And that can keep your negative screen rate high when appropriate and reduce your positive screen rate that requires follow-up testing. And when you have a nodule that's touching the pleural surface with acute angles, that is lobulated like this, or has both solid and ground glass elements, these cannot be classified as benign intrapulmonary lymph nodes. So understanding the difference is important. I want to mention the S modifier in Lung-RADS because these are the other incidental, actionable, significant or potentially significant findings that we see on chest CTs. You can see them in the lower neck, you can see them in the upper abdomen, but they're actionable and potentially significant in terms of clinical management. In the American College of Radiology's lung cancer screening registry, we looked at the first 1.7 million screens that were entered into the registry, and 19% of those screening exams, the radiologists reported one or more actionable, significant, or potentially significant incidental findings. 19%, that's 1 in 5. Of those, just over 15% had one of these types of findings, but 2% had 2 incidental findings that were important, and about 0.5% had 3 or more. And this speaks to the risk that this patient population that is generally older, has a high cigarette smoking exposure, are at increased risk for other diseases. The most common incidental significant finding is moderate or severe coronary arterial calcification. Again, patients who smoke cigarettes are at risk for cardiovascular disease, and we see coronary arterial calcification on these chest CTs very commonly. And by identifying it, this can lead to behavioral modification or medications to lower their risk of cardiovascular mortality. So this is probably the most important one to call out. But about 3% of people will have a mass not otherwise specified in an organ that could be in the lower neck, like the thyroid gland. It could be in the mediastinum, a mediastinal mass, esophageal abnormality, or in the upper abdomen, a renal mass, a liver mass, adrenal mass. Some that could be cancer and would need additional follow-up imaging. About 3% of people will have pulmonary fibrosis or interstitial lung disease. We tend to think about emphysema related to cigarette smoking. We tend not to think about interstitial lung disease as much in this patient population. But if you add up all the cases of ILD and pulmonary fibrosis, it's almost 3%. The early detection of pulmonary fibrosis is very important to preventing progression and beginning antifibrotic therapy. So when we identify interstitial lung disease on our lung cancer screening CTs, we refer them for pulmonary function testing and to see a pulmonary medicine physician. Now you'll think, well, why is the emphysema rate here only 1%? Well, it's because we only ask radiologists to classify emphysema as a significant or potentially significant finding when it's moderate or severe. The majority of people on lung cancer screening exams who have emphysema have mild emphysema. So this is underrepresentation of the total. It represents the most severe emphysema for further testing and management. Patients with moderate and severe emphysema should undergo pulmonary function testing. And in some cases, they may be eligible for emphysema-related procedures like endobronchial valve treatments to help decompress and collapse portions of hyperexpanded lung. And lastly, about 1% of patients will have an aortic aneurysm, usually a thoracic aortic aneurysm. And these, of course, can be life-threatening and important to be followed depending on their size and referred to cardiac surgery and cardiovascular medicine specialists for further evaluation. Our referring physician community, our primary care physicians have said, I get this lung cancer screening. I understand you're finding nodules. I understand that you're going to follow them with either short-term CTs or return them to annual screening for most patients. And a small percent of patients are going to go on for a diagnostic assessment and referral to specialists. But you see all these other incidental findings, and primary care physicians kind of scratch their head and say, well, what am I supposed to do with these when I get them in the radiology report? But the ACR, we took all of the ACR's white papers on incidental findings that were relevant to lung cancer screening, ones in the neck, chest, and upper abdomen. And we basically created a one-page guide for primary care physicians and nurse navigators of lung cancer screening programs to say, well, if you have this finding, it's okay. Nothing needs to be done. For example, in the adrenal gland, if you have adrenal calcification, there's really nothing to do for it. If you have a fat density nodule that's reported as an adenoma, again, you don't need to do anything. But there are other nodules that you do need to do something about. And so we've done this for each of the categories of organs that we see on lung cancer screening exams. We tested it on a lung cancer screening program coordinators, and it's been very well received. So again, this is for the non-lung nodule findings, the non-lung cancer findings, which we see quite often. But where are we in the U.S. right now? The most recent data we have is from 2022. Reports that about 16.5% of individuals nationally are being screened. I'm happy that in my own state of Michigan, we're at about 1 in 5 people who are being screened. It varies across our states, and so we have a lot of work to do. From a low of 8.5% to a high of almost 30%. And with this new expanded population that the American Cancer Society has recommended, we're going to have to see where that goes in terms of bringing those folks in for screening, because we need to try and work through that coverage and reimbursement so those patients can get cancer screening. But a couple things that are different about the lung cancer screening population than about the general population. If we look at individuals who are high likelihood of having lung cancer, there is a high rate of poor health status in general and variations in race and ethnicity compared to the general population. And what we found is that racial and ethnic disparities are evidence in lung cancer screening and lung cancer screening eligibility, even when adjusting for many of these factors. When we dig deeper and try and ask about individuals who are eligible for screening, um, what do they think about lung cancer screening? It's one thing to say you've got a guideline, you should do it, they meet medical criteria for it, but why are patients coming forward in droves for lung cancer screening? What are the things we need to know about people? And it may vary from country to country. In the US, this is a study that I found very interesting, that people who are at high risk for lung cancer by virtue of cigarette smoking are supportive of screening in principle, but they doubt its ability to deliver a long-term survival benefit. They have seen their parents, their grandparents' generation, their siblings, generations of heavy smokers being diagnosed with advanced cancer. And that is what the face of lung cancer has been to generations of individuals with a heavy smoking history in communities and in families. So they're skeptical because they've seen many loved ones die of advanced cancer, and they've seen what that looks like firsthand. So to them, lung cancer is perceived as an uncontrollable disease. And so why get screened if you can't do anything about it? So this is what we need to change to help people realize if we catch it early, it won't look like that anymore. So there is a feeling of fatalism, worry. They're already worried about the risk of lung cancer, and kind of fatalism, nihilism. Well, I did it to myself. I smoke. Maybe I don't deserve it to get screened or deserve to. And fatalism that you can't do anything about it anyway. This perceived blame and stigma around lung cancer as a self-inflicted disease. It's something that comes through strongly in interviews with people who are at risk for lung cancer due to cigarette smoking. And then, interestingly, a lot of people in this population don't think the lungs are a treatable organ, and that's why the survival is poor. It's just a lay explanation. Well, you can't treat the lungs. You can't take out my lungs. I can't breathe if you take out my lungs. Say, compared to a colorectal cancer, where you're taking out a polyp, or breast cancer, where it's not considered, it's an organ that you can remove and survive from vivisection. This lung cancer stigma is very real, and depending, and this varies internationally. In the US, it's particularly strong, as we had some, I call them the super scary ads from our Centers for Disease Control that would try to scare people with imagery about what disfigurement looks like if you had head and neck cancer, with stomas and disfigured post-operative pictures that scared people to quit smoking. And it actually did work, but unfortunately it created this secondary effect, which is stigma, shame, blame, fear, which doesn't cloud other cancers in the U.S. So there's some impact of this in other countries as well. So we're trying to change the face of lung cancer as a treatable disease, as a disease of hope, and hopefully treat people using patient-first language. The International Association for the Study of Lung Cancer has published a patient-first language guide, and our American Society for Clinical Oncology has published this language of respect. Some simple words like not calling an individual in our language smoker, but an individual who smokes as a risk factor. And both the Journal of Thoracic Oncology and the Journal of Tobacco Control now use this type of these guides in reviewing all the papers and abstracts that are submitted to their journal and their organizations for publication presentation. So we don't use the word smoker. We're trying to eliminate that word from our language and use patient-first language. A person who smokes, a person with nicotine dependence, and so on. So I'm honored to chair the National Lung Cancer Roundtable at the American Cancer Society, and we have 3 priorities. One is to accelerate the uptake and implementation of early cancer detection. Lung cancer screening is squarely there as our incidental pulmonary nodule programs. Our second initiative is to improve guideline-conformed lung cancer staging and optimize the use of biomarker testing in practice so people can get that appropriate immunotherapy if they have advanced cancer, and it can make a huge difference in their survivability of this disease. And then our third is to promote initiatives to eliminate lung cancer stigma and related nihilism. We know that there's lots of barriers to uptake of lung cancer screening. They will be different in different countries, whether it's social perception, whether it's policy and advocacy, whether it's coverage and reimbursement, or whether it's just the way we set up our programs and optimize them. Let's get through this. The last thing I'm going to close with is in the U.S. we have a lung cancer screening day. November is Lung Cancer Action Month around the world, and for the last 2 years, because you're our third on the second Saturday in November, we have Lung Cancer Screening Day, and it's an opportunity for radiology facilities to be open on a Saturday morning or all day Saturday and educate people about lung cancer screening, bringing people for lung cancer screening, sharing with them the positives that can happen to their health by doing so. Last year, we quadrupled the number of people that were screened, or screening facilities that were open on our second annual screening day, and we're hoping to do even better this year across the United States. Our Veterans Health Administration, where we have a lot of a large population of high-risk individuals, participates in lung cancer screening day and has been promoting it along their population as well. So we're trying to move from foundations. We've talked about why we screen, who to screen, what to screen with, how to report the screen, and designing programs to setting programs up for success, making sure that we're providing the resources, and then measuring what we're doing to make sure that we're doing with quality and making the meaningful impacts that we think. So my closing message, lung cancer screening saves lives. Lung cancer screening saves lives, something that we can bring to our patient populations as a public health tool from a radiologist lens to improve the health of our population. Thank you so much for the opportunity to spend some time with you this morning.
Thank you, Dr. Ella, for your enlightening talk. I hope I'm audible.
Yeah.
So we have some questions in the Q&A. So we need to know what is the low-dose CT screening parameter for the protocol to say, how to report nodule, and any references that you would recommend.
Yes. So the technique of low-dose CT, the American College of Radiology, we have a practice parameter that describes all the details of what should be included. It recommends using a slice thickness of 2.5 millimeters or smaller. I'd say most practices use 1.25 millimeters. Using low-dose techniques, so trying to keep the radiation exposure down to about 1 millisievert. You can use ultra-low-dose technique if you have scanners that are fit with some of that technology, but trying to keep the radiation dose between 1 to 3 millisieverts in general. Recognizing that you're going to have larger patients where you're going to need higher radiation exposure to get a good quality image, and you're going to have smaller patients who need less exposure. So in our lung cancer screening registry, we actually track radiation dose by patient size so that we can show that not only our practice is using low dose, but they can also see if they're using appropriate dose for patient size. So 2.5 millimeter or smaller, and trying to keep the radiation dose between 1 and 3 millisieverts is the quick answer for the technique. Lung-RADS, which is our interpretation schema for nodules, solid, part solid, ground glass, cystic, airway nodules, and so on, is on the American College of Radiology's website. If you were to Google ACR lung cancer screening resources, you'll get to a page which has links to lung-RADS, the practice parameter, and a lot of other resources about lung cancer screening at the American College of Radiology, the Incidental Findings Guide, and so on. So it's a great resource, ACR lung cancer screening resources, to Google that.
Thank you. We would also like to know how to differentiate between some granulomatous infection, like TB being quite common in this part of the world, and malignancy.
Yeah, I do some work with the International Association for the Study of Lung Cancer, International Organization, and also with the Lung Cancer Policy Network. And the issue of doing lung cancer screening and in areas where there's tuberculosis or endemic fungal infection comes up pretty regularly as a potential challenge. When have a couple pockets, I would say, in the U.S. We have endemic fungus in the Midwest. We have histoplasmosis in the Southwest. We have other fungal infections. And so we have a higher rate of non-calcified nodules, which means we have a higher positive screen rate in general in some parts of the country than others. Tuberculosis is a real challenging one, as are other mycobacterial infections, because within the areas of abnormality that you're recognizing, treating, and a lot of the mycobacterial infections can be chronic. It can be a confounder. So what we really enforce is kind of making sure you're getting treatment, but then also it's looking for change between scans that becomes the most important thing. But it is definitely a challenge.
Oh, yes, it is a challenge here as well. A little deviation from the screening talk. Often in patients with known cancers, we encounter multiple lung nodules or maybe even a few or solitary lung nodules, which can be less than a centimeter or so. So, do we apply the same incidental finding criteria as is available for the lung cancer screening or lung grants, or how do we address these issues?
Yeah, so I think it's important to distinguish between lung cancer screening, which is people who've never had a diagnosis of lung cancer, and lung cancer surveillance, which is people who may have had lung cancer diagnosed already. They may or may not have had surgery, immunotherapy, radiation treatment, and so on. And to separate those. So once you've had lung cancer, you're really no longer screening eligible, but you move into lung cancer surveillance. The National Comprehensive Cancer Network is probably the most cited guidelines for patients with lung cancer, and we make it very clear that screening never had lung cancer. Once you have lung cancer, you move into the lung cancer guidelines in terms of follow-up. For people who get to a certain point after their cancer treatment, they move into surveillance mode, and it's very common to find nodules. These patients are at higher risk for a second cancer than the people that we screen because they've already had lung cancer. And so when we do have nodules in patients with lung cancer, we tend to follow them a little bit more aggressively because they're at such high risk of lung cancer. So we don't use lung grants once a person has been diagnosed with lung cancer. And so their intervals for doing follow-up may be 3 to 6 months on a regular basis, depending on what's happening with the nodules they have.
Thank you. So many questions pouring in. In fact, your talk is quite well received. So if you may, the other question is about juxtapleural nodule. Is there any criteria for defining a juxtapleural nodule? Any distance cutoff that one should look at?
Yes. I will say in the Journal of American College of Radiology, we published, and I believe it's open access, LungRads 2022, which has some nice illustrations and definitions and references. So a juxtapleural nodule must be on the pleural surface, whether it's any pleural surface, along the ribs, the mediastinum, the diaphragm, or a fissure. It must be under 10 millimeters in mean diameter, and it must have the preponderance of its shape along the fissure. So if it has acute angles to the fissure or acute angles to the costal pleura, you cannot call it a juxtapleural nodule. It has to have its base or its length on the pleural surface and be triangular, triangular, angular and shaped, not round and three-dimensional.
Okay. Any application of AI in cancer screening which you may be using for research or in practice?
I would say 100% absolutely yes, and for a couple of things. One is detecting nodules, right? You're looking at a lot of images, make it easier to find the actual nodules. When it finds the nodules, measuring the nodules, whether you're using diameter or volume, and then comparing it to the last CT to show you what the volume doubling time is. So I think huge applications for AI in practice. We've used the tool at our institution actually for a decade now, and we've watched it get better over time. That detects the nodules for us. It measures them, shows the growth rate from the pair, and we also have it integrated into our reporting system, so it puts the output into our reports to make it easier where we have the series and the slice number. So as the radiologist comes back the next time around, you know exactly what nodule and what slice and what series to go and find it. So we found AI to be incredibly helpful, and I highly recommend we use it on all of our chest CTs, not just like dentistry.
So are those tools proprietary or they are available for anybody to use at any?
There are many vendors who have these low nozzle detection tools, and they've been, at least in the U.S., FDA approved for a number of years. Like I said, we've had one that's been commercially available for over a decade that we've been using, and it's gotten better over time. And I'm really happy with where it is right now. But these are commercially available tools for nozzle detection, measurement, and growth.
And is there an indication for IV contrast for lung screening for high risk groups?
So in lung cancer screening, no contrast, no oral, no IV, no prep. Most people don't even have to change their clothes if they don't have anything metal on them. They just get up, lay on the scanner, take the picture, and off they go. So as it's the most minimalist CT we do, no contrast.
So that's been a great session, Dr. Ella. And again, thank you for taking out time on an early Sunday morning and giving us your insights on this very important topic. And I also thank all the participating audience and their interaction with us during this session. So I wish you a very good day and everybody else a good day, good evening, and good night. Thank you.
Thank you, Dr. B. Thank you so much for the invitation. I really appreciate it.